So I was recently talking to a client and he said and this was an older client that's been on, and he said he was still confused about how things come together. And I'm like, okay, remember, we've dumbed this down unbelievably easy. So the first thing, I mean, there's really just 3 sheets of paper you have to know. Three outlines. That's it, essentially. Okay. So number one is the checklist. That is the 30 categories of diagnostics. There's whether it's an MRI, an X-ray, orthopedic test, palpation, muscle test. There's 30 different categories. Okay. That's a checklist. So you should have that. And when you're doing your consultation or exam, that checklist should be in every one of your PI cases just to make sure you're doing what needs to be done. And I got to be honest with you, if you can't follow a checklist, you got some serious problems. I mean, that's why they call it a checklist. You just, you follow number one, and then you follow number two, and then you follow number three. I mean, I don't know what to say. It just doesn't get any easier than that, besides somebody just doing it for you. So that's how you keep documentation of did you do all the tests that were highly probable, highly sensitive for the low impact soft tissue spinal injury. Okay, so that's the checklist. You should just have all that. So, I mean, I don't know what to say about that. And then we created a checklist for the value of the potential value of the case. We created a checklist. We said that's the 7 minimum categories of documentation that was necessary to be fulfilled to have a good case. In other words, to stop a low ball offer and create a high value offer. What were the 7 categories? The bare minimum categories. 1, mechanism of injury. 2, subjective, at least one primary subjective finding at MMI. 3, at least one hybrid finding at MMI. 4, at least one objective finding at MMI. 5, did the patient reach MMI? That's important because now that allows for a potential impairment, which comes to the next one. 6, was there an impairment rating? Number 7, what's the prognosis and need for future care? That's the checklist. That's the minimum checklist to see if you have a value case. Now, we do go deeper into the subjective, hybrid, and objective, and we say, is this primary evidence? And how many pieces of primary evidence do you have? How many pieces of secondary evidence do you have? And how many different categories of evidence do you have? Well, all of those increase the value of the case. So if I only have one piece of primary evidence, that's the bare minimum. If I have one in subjective, hybrid, I'm at the bare minimum to have to stop a low value case and turn it into a high value case. I'm at the bare minimum. But we're going to pay attention to more than one. And when I say primary versus secondary, this is really simple. Primary means it's directly related to that injury, directly. So, as an example, a foraminal compression test is very specific anatomically for the ligamentous lesion. Okay, that's okay. Do shoulder depression test, that's not specific. It's kind of more general. So that's all. And this is your interpretation. There is no book that says this is a primary test, this is a secondary test, and this test is totally irrelevant. There's no book. The book is in your mind. The book is your knowledge. When you do that test, is it a specific test for that problem? Another example is motion x-rays. If you want to check the integrity of the ligaments, you have to do motion x-rays. Static x-rays will not do it. It's the wrong test. It's not even a secondary test. It's the wrong test. Same with MRI. It's not even a secondary test for a ligament. It's the wrong test. Now, it's the primary test, the MRI, for a disc bulge. The flexion extension view is not the primary test for a disc bulge. So you got to know the anatomy, you got to know the test, or you got to know the mechanism of injury and the anatomy, and then you got to know what's that test testing. That's what determines whether it's a primary or secondary. Secondary means it's supportive. Generally speaking, a primary test, if it was positive, gives you the diagnosis. It's definitive for the diagnosis. A secondary test is not. And we use that example all the time with blood tests. You have positive high C-reactive protein, pro-inflammatory, inflammatory indicators. What does it mean? Well, it's primary for inflammation. It is not primary for a disc bulge. It is not primary for a fracture. It's not primary for a ligamentous lesion. It's just saying there's something wrong. There's inflammation going on in the body. So you've got to look at these tests and go, is that a primary? Does that directly involve that anatomy? Specifically, I'm talking about in the plane of motion of the injury, not just neck. There's a lot of tests for the neck. Okay. Direct compression, that's worthless for a ligamentous injury. Okay. So, we'd probably call that secondary direct compression. If that. Distraction, well, that could be definitely a primary test for a ligament, right? Okay. So these are the difference between primary and secondary. And obviously the more primary, the better, whether it's for subjective, hybrid, or objective. And then if you have secondary, that's good. And then it's good if you have more than one category. So in the subjective, if the person not only has neck problems, but they have low back problems, or they have neck and elbow problems, or neck and shoulder. See, those are two primary categories, two different categories. So same with your hybrid test. Are they in different categories? Do we have hybrid tests that are positive in the muscle category, the nerve category, the range of motion category? See, palpation, fixation. Do we have tests in each of those categories? Well, the more categories that you have, the more solid and the more you're substantiating the validity of this case, the power and the strength of this case. What's the bare minimum? One positive finding, one primary positive finding at MMI in subjective, hybrid, and objective. That's the absolute bare minimum. And then you go over to the objective, and it's the same thing. Do you have any objective test and how our primary objective test? See, and that's why we talk about the dynarom is not primary for a ligamentous lesion. It's primary for abnormal muscular firing. It's primary for spasm. It's secondary for a ligamentous lesion. It's secondary for a disc bulge. Okay? So this is how you kind of separate it out, and you know what you're talking about. Well, this is knowing basic anatomy, knowing basic mechanism of injury, knowing plane of motion injuries, knowing the particular test, and what is that particular test evaluating? Because remember, it could be high or low sensitivity test. It could be probable or not probable. I mean, there's all kinds of tests. That doesn't mean we just do them and they all have the same relevance. They do not. And some tests that are great for one particular injury are worthless for another injury. So knowing this matters, whether it doesn't matter if it's an orthopedic test or a diagnostic test, whatever. Okay, so that now tells us, do we have a strong case? How strong of a case do we have? Well, what's the bare minimum? Do you at least have all those categories fulfilled? And do you have at least one primary? That's the bare minimum. And you should be able to explain this to your attorney. This is what determines the strength of a case. That's a checklist. Now, I'm pointing this out to you for a reason. When you go and do the case evaluation, the financial driver case evaluation, after the presentation, we make an offer to get the ball rolling with referrals, right? But remember, the main reason we're doing that is to show them authority and credibility. That's the main reason we're doing it. To show them, you know what the hell you're doing. That's why you're gaining their trust, their confidence, your authority. That's what. And you're not only doing that, you're showing them the people they are working with are crap. So it's kind of a bifurcated process. You have to be able to do that. You've got to be able to show the value of a case, whether it's a good case or not case, or a strong case or not. Well, that's how. You just pull that chart out. Now, remember, that's the minimum. What are some other factors that would play a role? Well, injury magnifiers would help, but do you definitely need injury magnifiers? No. Medications that affect the healing process would help. Do you need them? No. Home care. Do you need it? No. Surgery. Do you need it? No. Would they help the case? Would all of those things help the case? Yes. Do you need it as a bare minimum? No. The amount of property damage? No, you don't need it. See, those are all ancillary factors. So the absolute core is the 7 with primary. How many primary categories do you have, and how many secondary? And then how many categories are they in? Do you have x-ray? Do you have blood test? Do you have a dynaram? Do you have an MRI? Well, you got, if you got a disc and you got all 4 of those, that's strong in the objective category. See, that's a real strong. And then, of course, we want to fill it up with the hype. Now, here's my point. When you do the evaluation, when you do the checklist. Oh, let me finish and then let me come back to application. Then you come over to, okay, you go, well, now you're showing the attorney, this is why this is a strong or weak case. And remember, that is the single most important thing you need to get across. And this takes away from whether or not it's a good case or not, irrelevant to you in getting referrals. You do not want to tie yourself to there being good cases and putting that kind of pressure on you. You're going down the wrong road because they're not all going to be good cases. And it means if that's the road you take, you're guaranteed to fail. That's why you don't want to go down that road. The road and by the way, that's not the road they're looking for. They're looking for consistency, not a one-off. They want somebody to know that they have bad cases too, or the degree of a good case. See, remember, they only look at property damage and MRI and surgery. That's all they look at to determine, the attorneys, to determine essentially if they think it's a good case or not. They don't know all these things that we're covering, is the 7 minimum categories, how much primary evidence, how much secondary evidence, and how many categories. They don't know that. You're the one that has to know it. You're the one that has to explain it to them. Now, the last sheet of paper over here is the 4 injury awards. Because after you say it's a good or bad case or not, the very next question is, what do you think it's worth? Meaning you have to know the formulas, the basic formulas of the injury awards. So remember, when it comes to the doctor's documentation, there's the medicals, the impairment, pain and suffering, and then the prognosis and need for future care. Now, we talked about the medicals are pretty straightforward. It's real easy to justify those with the 3 phases of healing. What biomarkers did you have for the inflammatory phase? What therapies you did? What was the frequency you did them? And what was the cost? Okay, I just justified the inflammatory phase medicals. I'm going to do the same thing for the repair phase. What biomarkers, and remember the goal of the repair phase is to increase active, passive, and joint motion. So those are the biomarkers I'm going to be paying attention to. Which ones did I have that were positive? What therapy did I do to help correct that or get it back to normal as much as possible? What was the cost of the therapy? What was the frequency of therapy? I just justified my repair phase. I'm going to do the same thing in the remodel phase. What's the goal of the remodel phase? Clinically, it's to increase strength and activity. It's to do all of those, decrease pain, inflammation, increase active passive joint motion, and that if any of them still apply, and now increase the strength and elasticity. You go, okay, what were the biomarkers? Well, I'll look at are we still dealing with any of the past? If we are, we need to handle that. And then I'm going, okay, what was the strength and elasticity? What were the biomarkers that showed that were positive? What was the therapeutic protocol you did? What was the cost of that therapeutic protocol? What was the frequency? Until, of course, they reached MMI. I just validated how the injury. Now, that's typically 3-to-1. Where do you get this 3-to-1 stuff? A third goes to the attorney. Typically, a third is in the cost, and a third goes to the patient, the victim. That's where this 3-to-1 occurs. And it used to be normal decades ago. That was the norm. And then after they brought Colossus in the 90s, that's what started gutting all this 3-to-1. And of course, the doctors and chiropractors didn't know how to document. Document meaning all these categories. I call vertical, horizontal, and vertical documentation. Horizontal and vertical documentation. So what do I mean by that? Horizontal, 7 categories. Mechanism of injury, subjective, hybrid, objective, MMI, impairment, prognosis. That's horizontal. Vertical, how deep? Primary, secondary, number of categories. Vertical, horizontal, vertical documentation. There's the chart. This is a chart. This is a simple checklist. Then we come over to, and then I talked about the ancillary factors, okay, that will be supportive, whether it's home care, medication, surgery, the amount of property damage. All those are secondary factors. They're totally worthless if you don't have the bare minimum 7. That's why they're secondary factors. Then you come back over to the formulas. And remember, we said these are good generic formulas. They will vary depending on your county and your region or your state. You have to verify how injuries are awarded in your county. That's why we talked about getting to the Trial Lawyers Association. And you need to find out what are the typical injury awards for the low impact soft tissue spinal injury. What is that? Okay. But these are good generalizations. Okay. These are great starting points. And some of them, this is the way it is anyway. When we go to impairment rating. So back to the, just a second, back to the medicals. So we documented the medicals and then we go, well, that's 3-to-1. Then we come over to, that's what's asked for and demanded. That's what a strong case does. Or greater, 3-to-1 or greater. And then you come over to impairment and you go, well, a real easy way to associate impairment is go from the start of the accident to the point of MMI. That's the injured. What was the potential lost income, even if they lost it or not? Because impairment, you're impaired. So that's one way of doing the impairment. And then you go to, and again, that's 3-to-1. Why 3-to-1? One goes to medicals, a third goes to the attorney, a third goes to the victim. So after it's substantiated, it's 3-to-1. That's what the attorney should be asking for. Then you go to pain and suffering. Well, we got all the categories to support a strong pain and suffering case if you have the 7 minimum. So pain and suffering is the same time from the point of the injury to MMI, the amount of money potentially lost. Even if they didn't lose it, what were they making? Multiplied time a factor of 1 to 5. The magnitude of the injury. This is right out of workers' compensation. Remember, most of personal injury takes workers' compensation guidelines. There are no personal injury guidelines. There's workers' compensation guidelines, and most of the time, that's what personal injury uses. So we come over to the pain and suffering. Do we have the 7 categories? Yeah. Do we have how many primary? How strong is that, right? So, okay, we go. So now you go, how much potential money was lost from their income from the point of injury to MMI times a multiple of 1 to 5. There's nowhere in the book that'll say 4 is XYZ. Remember, they can't have every lesion in the world in a book. There's no book big enough to hold every freaking lesion. So at some point, you got to use common sense. You got to use guidelines. So you go 1 to 5. And if we go, well, 5's the worst, 1's the not, we go, well, where's this apply? Well, I'm just going to look at the quantity and quality of ADLs. That's what's going to give me my justification. Because remember, when we're talking about impairment ratings and permanent ratings, we're talking about pain and restrictions that are permanent the rest of that person's life. So that's where I'm focusing. I'm focusing on the pain and restrictions that are permanent. Well, I'm just going to go, well, how many were involved? What was the quality involved? Were they important to that individual? That's your call. You could say they have 1. You could say that's enough. I think it's a 5. You just have to ask yourself, how much sense does that make if you were to say that in front of an 8th grade educated jury? How much sense would that make? That wouldn't make a lot of sense. That better be one hell of an ADL. And it's not going to make a lot of sense that there's only 1 ADL that has pain and restrictions, and none of them do. But that one is off the charts. That's just not even, that defies common sense. Okay. So again, it's just the quantity and quality of ADLs. I'm going, okay. And it's your choice. Just like when you give an impairment rating and the AMA guide says, well, you can give 25% or 28%. That's your choice. What's the quantity and quality of ADLs that have been affected? 2 might be enough for you. 5 might be. You might take 10. I don't know. It's your choice. You just have to be able to justify it when you regurgitate it to an 8th grade educated jury. That's what you just better be able to do. That's just my suggestion too. And that's just called common sense. Because remember, that's the ultimate decision maker. So you might as well just start that way. Everything you do with your documentation should just start with the end in mind. How's this going to look in front of an 8th grade educated juror? Or don't say it. Or if it sounds stupid, don't say it. Don't do it. Okay. Then you go to the prognosis and need for future care. That's pretty straightforward. What therapeutic protocol was needed at MMI for palliative care? Usually it's pain, inflammation, muscle spasms. That's usually a range of motion. Those are usually the therapies with the low impact soft tissue spinal injury. So it's totally based on, not your opinion, on them. It's based on the patient's biomarkers at MMI, because that's what you should have been doing. If they had the biomarkers of pain, you should have been doing something for their pain. If they had the biomarkers of joint fixation, decreased passive range of motion or active, you should have been doing a therapy for it. Should have been documented. You should have been doing it. So now it's totally justified by the biomarkers what therapy was needed for palliative care. Now remember, this is palliative care. We're not talking about trying to increase their strength anymore, their elasticity. This is palliative care, how you feel. Okay. So there's your palliative care. Multiply your palliative care therapies times the cost, times the frequency, times the patient's actual lifespan based on an actuarial scale. If the attorney wanted to multiply and include inflation, he could, right? All right, but that's the bare minimum. It's real clear. It's very easy to show that to an 8th grade educated jury, okay? That's what you would say to your attorney. These are the guys, and remember, these are really, really good guidelines. Now, your county may have a little differentiating between one or another, et cetera, okay? Like I've seen some counties that'll include the impairment with pain and suffering. I've seen that happen before. So, but again, if they don't even ask for it, they won't get it. But remember, especially in a court or trial, the judge is going to give them guidelines. The judge is going to say, here's the limits of what you can ask. Here's the categories of what you can ask. And some of them only apply to you. There's some that don't apply to you at all. Getting a rental car has nothing to do with you being the doctor. The damage to the car and fixing it has nothing to do with you being the doctor, see? So there's other factors, but 97% of the injury award is the doctor's documentation, like what we just said. Okay. That's it. That's the simplicity of essentially personal injury. So you got 30 different diagnostic categories. It's just a checklist. Do them at your original exam and re-exams. Then you go, okay, you're done with it, right? You're at MMI. You go, well, let's say you're doing a financial case evaluation with the attorney. I'm going to get all the documentation they have. I'm going to take my chart, my 7 minimum categories, right? I'm going to go, what documentation do I have? Do I have private? What category does it go in? They may actually show injury magnifiers. Great, I'll add it. It's not mandatory, but if they show it, I'll add it. Maybe he had surgery. Is it mandatory? No. But if he shows it, I'll add it. Okay? But those are the 7 minimum. You better have those 7 minimum horizontally and at least 1 in each of those categories. That's a solid bare minimum case, period. You can take that in front of any jury and make sense of it. Okay?